I should say from the outset, I'm not going to go through a list of operations. Having reached the final ripe old age of retirement, I thought what I'd do is try and look back over some of the issues we faced and how some of them we might address and what we can learn from what we've done. So it's a little bit of a philosophical talk because it gets boring talking about double switches, pulmonary treaties, goodness knows what else. And you can read English as better than I can, so you can follow them. Somebody asked me where Birmingham was, and this is our hospital, and it's interesting with the National Health Service. Our hospital is, where are we? Does this work, this mouse? Anyway, it's on there we are. It's a 200-year-old hospital with the National Health Service. Fortunately, they don't keep the physicians and surgeons for 200 years, otherwise there would be no progress at all. Birmingham is quite a modern city, and this concert hall on the left here, you nicked our favorite conductor to conduct the Berlin Philharmonic, Simon Rattle, so he's with you now, though I gather he's going back to London. And it's an interesting city. It doesn't have rivers, it has canals, and it was an old industrial city. It's the second largest conurbation, or it's the largest conurbation in the UK. It has some 10 million people that it drains. So we're in the middle of the old industrial area. And I said some philosophy, and the reason I'm doing that is because, as was highlighted in some of the previous talks, when you're in the advantage of being in a center for 20 years or more is that you can follow the patients up. The disadvantage is you see them coming back for reoperations. And you always wonder, it seems quite a quick time, 10 years for us passes quite slowly, but for the patients, it's very quick. And I think that some of the talks this morning highlighted the need to give more time out of the operations. Can we do operations better in the first place so they last for longer? How can we modify operations and valves and so forth so they last longer? And I can't answer that question, but I would like to try and highlight some of the areas where we might try and improve. And there's the quality of life as well. We're operating on more and more complex conditions, and I'll illustrate that, and you know that very well. But there's the survival versus the quality of life, and how do we address those? And in our Birmingham meeting in May this year, we're planning to have a whole morning on the ethical issues of what we're doing. I think it's important to look at that. But if we look at the PICU, where I was in Melbourne, and they've just published a follow-up of their patients there, illustrating really that over the last 3 decades, the length of stay in the pediatric intensive care unit, and this is for all children, but it reflects equally on cardiac patients, the severity of illnesses have not changed, but there's been a substantial reduction in pediatric intensive care mortality. However, the proportion of survivors with moderate or severe disability has increased significantly. Some children who had been allowed to die in 1982 and 1995 were kept alive in 2005 and 2006, but survived with disability. This trend has important implications for our patients, their families, where it can often be very destructive, and for the community as a whole. And I think that we're at that stage of what we're doing now. Years ago, fallows repair, VSD, ASD, ducts, whatever, you repaired them, sent them on their way. Now we're getting a group of patients coming through where they have continuing issues about follow-up, need for reinterventions, and not infrequently some morbidity. And you may recognize this fellow. I hesitated to show him over here, but there we are. As well as being a great wartime leader, he had a lot of useful sayings. One of them, which isn't here, which was quite amusing, he was talking to one of his generals during the war, and the general said, he said to the general, "Would you like a cigarette? Would you like a cigar? Would you like a drink?" And the general said, "No, I don't drink and I don't smoke, and I'm 100% fit." And quick as a flash, Churchill came back, "I drink and I smoke and I'm 200% fit." Well, anyway, so you can see the sort of person he was. But he said also, however beautiful the strategy, and we have strategies for our patients, you should occasionally look at the results. And he also said success is the ability to go from one failure to another with no loss of enthusiasm, which I perceive is probably more difficult. And this is illustrated in the history of cardiac surgery by Dwight Harkin in a way. He did, in 1947, closed valvotomy, serious mitral valvotomy, with 6 consecutive deaths. He was very depressed, and I think a lot of surgeons and some interventionists now there on the interventional route get depressed with some of their results. And he went to bed. His cardiologist, Brewster Ellis, came to see him but persuaded him to continue. And he said, you know, you've really got up and get going. You should not waste the experience of 6 early deaths. You're the one in the world with the most experience of this condition. And success followed, and we know the history. We know about the arterial switch procedure, and it's arguable these days whether that could start now as it did 20 or 30 years ago. Clinical outcomes in good 20 years after our switch, the aortic root dilatation is present in 66%, moderate aortic regurgitation can occur, but in the first operation in 1977 in Holland, mortality in the first 5 years was 50%. So, you know, you've got that balanced against the sending and the mustard and so forth. And then another example of perseverance was, of course, with Shumway, where he, following Barnard's and multiple centers throughout the world trying the transplantation, he persisted, and with the introduction of cyclosporin, was able to open up a new area of transplantation. And so these early examples of mitral valve surgery, arterial switch, transplantation, illustrate the determination to succeed despite initial bad results. However, it also highlights the distress of Harkin and the death of his patients, the perseverance of Shumway with transplantation, and the historical timing with the introduction of the arterial switch. Could it be done today? And I think set against that background, I feel also for our own patients and surgeons, there's a lot of publicity in the UK with any problems within a heart center, within a heart unit. And it's important we produce surgery which protects the patients. But I think there's another issue these days, in the way we work together. We need to protect the young cardiologist and the young surgeon, because failure is not something we can accept so readily in these days. So how has practice changed over the years? Well, I can illustrate that quite easily by looking at the Birmingham series, because it's the same more or less everywhere. We have between 400 and 500 bypasses a year, but it would have decreased by 200 cases now, because the cardiologists are performing repairs or corrections in 50% of the patients we used to operate on. And that's ASDs, PDAs, pulmonary valvuloplasty, aortic valvuloplasty, stenting, and pulmonary valve replacement. But counterbalancing that is the increase of 200 cases or more with CCTGA, complex pulmonary atresia, and notably the surgery for univentricular hearts. The introduction of the new procedures, arterial switch, double switch, staged complex repairs, pulmonary atresia, Ross procedure, Norwood procedure, DKS, the whole gamut of operations have become very complex. For me, and I may be wrong, Shaq and the rest of you will probably end up doing it in 20 years. It's hard for me to see how you do a double switch with a few wires in the vessels, but you never know the way you're going on these days. And so this illustrates the increase in our catheter interventions, now some 200 a year with embolization of vessels, VSD closure, and at the bottom there in blue, PDA closure. So it gives you an idea of how things have changed from 1988, when I first went to Birmingham, to the recent times. And univentricular surgical activity makes up 25 to 30% of our program at this time, with Norwood, second stage Glenn, and the Fontaine or the TCPC. So 120 or so procedures a year in these conditions, and most of them, of course, reoperations. More specialized centers, I think, have occurred over the years, with centers referring in univentricular work to centers which are doing that sort of work. We've got the prolongation of life by transplantation, ventricular support and ECMO, which have added another complication to the management of our patients, saving lives, but also creating some problems into what can we do. Is that an end-stage therapy? It isn't, obviously, but we have no answer to those patients. If we have at one stage, we had 12 patients in the UK on LVAD-type support, and very difficult to find a way out for them with transplantation because there aren't the donors available. So this is our Fontan TCPC activity over the years. And I show this slide because there's more than 700 now Fontans in our area that our cardiologists are having to follow up. And you know from your own experience, from a cardiologist, one Fontan patient can tie you up for a week with their complications and their problems. So these are the sort of issues we've built up over the years. Now, I'm not saying we shouldn't be doing it. I'm questioning whether we should do it in each case. And can we find a way out for these patients that we start operating on in their complex, with their complex problems as a neonate? And it greatly impacts on the health service and the costs of the health service. So even our adult colleagues now are following up over 250 now, Fontans, age ranging from 17, which is when they transfer over, to 64 years of age. But it's not all gloom and doom. There have only been 13 deaths in the past 10 years in this adult population. That doesn't mean to say it won't dramatically fall and become a problem at, say, 40 years average follow-up or 45 years average follow-up. But I don't think that we produced patients that are having problems in their 20s and 30s quite so much as we imagined we might do. But the question arises, is 40 years of life worth having? Is 50 years of life worth having if it then comes to an end? And these are philosophical, ethical discussions which I don't need to enter into here, but I think are issues that often the families ask when they present antenatally with a baby with a complex heart problem. I guess you could divide surgery up into curative, ASD, VSD, PDA, corrective, fallows, and TGA, where they're going to need some further intervention, and palliative, where you have univentricular heart surgery, hyperplastic left heart syndrome, which are good illustrations where you're not restoring a normal ventricular circulation with 100% saturation. And these patients will require continuing follow-up into adult life in the majority of cases. And as been seen this morning already, may need valve conduit repair or replacement, and particularly arrhythmia interventions. And this is a whole mishmash, if you like, of problems that we have to deal with, which aren't clearly defined as to how we should deal with them, particularly for arrhythmias, for instance. Newborn undergoing repair of phallocentralogy, pulmonary atresia, TGA, AVSD, truncus arteriosus, for example, continue follow-up even though corrective procedure has been performed as an infant. And it's imperative that they are followed up because if they do present later in life with problems, and they present when they're symptomatic, it may well be too late. As an aside, it's also noted, and we're looking at this at the moment in our grown-up congenital group, these patients often present with other problems which aren't necessarily related to often their right ventricular outflow tract. For instance, mitral regurgitation, tricuspid regurgitation, aortic valve anomalies, which develop over the years in these surviving patients and may need addressing at the same time. For instance, if you're going in to a fallows to replace the pulmonary valve, do you deal with moderate aortic regurgitation at the same time? How do you manage a mild to moderate leaking mitral valve, knowing that you're going to have to come back maybe to deal with that later on, or do you deal with it at the same time? The palliative group, Norwood-type procedure, hybrid procedures for complex morphology, usually hyperplastic left heart syndrome, all lead to a Fontan circulation, which has many long-term morbidities. And these relate, of course, to the fact that we're diagnosing these patients and they're taking the opportunity, at least the families are, to try and palliate them. Now, I would propose to you philosophically, the problem is that these patients are being diagnosed around about 18, 20 weeks of age antenatally. And it's possible if they were diagnosed at 12 to 14 weeks in pregnancy, I suspect many families in the UK would take the opportunity of a termination of pregnancy in that situation. At 18 to 20 weeks, maybe it's more difficult. We also have in Birmingham the issues of ethnicity and religion related to family views about how to deal with these patients. Safe to say that at the moment, our termination rate in those patients who are diagnosed antenatally is around about 25%. So the majority, no matter what, will go forward to a full-term pregnancy. So that's the complex group of patients from interventions in early life that we are having to deal with in older patients. Having said that, as I said, the Fontaine group as a group in the older patients are doing very well in our experience. Can we improve the quality of outcomes by the timing and method of intervention? Can we try different cardiopulmonary bypass techniques, myocardial preservation, and the timing of intervention according to brain maturation? I'll just cover that shortly. And if we look at the timeline of human brain development, I'm not a neurologist, and I don't necessarily want you to follow this in detail, this slide. But really what it illustrates is that in that 6 weeks or so, from 24 weeks to the term to delivery, there are major changes in the brain, and they continue on after birth. And I don't think as a group we've addressed the issues as to interventions as to how it might affect the development and the maturation of the brain. We do know, it's been published, that some conditions with aortic arch anomalies, such as the hyperplastic group, when they're born, some of them have smaller brains than the normal population. And what are the implications for that in the developing child? And should that impact on what we decide to do for those patients? There's white matter damage, injury. And again, a lot of papers now have shown by MRI that white matter injury exists before we intervene. It's very easy for the surgeon to blame themselves and the cardiologist to say, well, we've intervened, we've done this operation, and look at the damage the brain has had. But we need to realize properly that beforehand there is also already white matter injury. Why is that, and what is the importance of that in the long run? And then there's a whole way we manage these patients: deep hypothermic circulatory arrest, normothermic bypass, different types of cardioplegia. And the group from Philadelphia and Boston showed, as best they could in 2010, that the children undergoing repair of heart disease in infancy, patients who underwent deep hypothermic circulatory arrest, had risk factors associated with worse neurodevelopmental outcomes. Despite these, use of deep hypothermic circulatory arrest to repair of single ventricular and biventricular heart disease without aortic arch obstruction was not predictive of worse performance for any neurodevelopmental domain tested at 4 years of age. So really what it's saying is, I think, that there's injury we can pick up, but certainly circulatory arrest, which is a great fear for a lot of modern surgeons, is not something that can be highlighted as a major causative factor. However, the group from Australasia has just recently published a paper showing new white matter brain injury after infant heart surgery is associated with the diagnostic group and the use of circulatory arrest, and that's arch problems. So you've got these issues. Now, therefore, if you postpone that surgery till they're later, do you do a shunt, for instance, or a corrective surgery? Are you likely to influence the way the brain is damaged and therefore the morbidity in the long run? We had a symposium about this in our EACTS meeting in Vienna last year. Pascal was there as well with Bill Gainer's group, and I think Bill Gainer, the group from Philadelphia, used a lot of circulatory arrest, cooling, and crystalloid cardioplegia. Pascal's unit was using normothermic bypass with no circulatory arrest and normothermic blood cardioplegia. And we felt in discussion among ourselves there was not possible to separate outcomes from these widely different methods. It does allow, however, for a surgeon, knowing that there's no difference, to allow a degree of freedom for the surgical practitioner to use different techniques according to the needs of the patient. For instance, with reoperations for complex pulmonary atresia, where you may need to operate far out into the highland of the lung to overcome obstructions. And finally, this is my final slide. I gave the Waterson lecture a few years ago in London, and Waterson of the Waterson shunt. At that time, and it goes throughout the years, and I think we all do the same, We can do this procedure, but should we? And Hippocrates, thousands of years ago, said, first do no harm. And I think that whenever we're introducing new ideas, new concepts, as Churchill said, we need to see what the outcomes are like. We may be able to influence those of practitioners. Quite often, ethnic and religious considerations come into view, into the play, which guide what we do. But I think it's a very good idea now at this time, with our univentricular program reaching adult life, with all the associated problems that we can see, that we stand back and take a really good hard look at what we're doing and why we're doing it and should we be doing it. Thank you very much for your attention.